Hello and welcome to today's WorkSafe Month webinar, Alcohol and Drug Use in the Workplace. It's a health and wellbeing issue. I'm Stephanie Morawski from WorkSafe Tasmania and I will be your moderator. Before we start, please take a moment to read the following slide about information received today. I'll now go over housekeeping. Here is a screenshot of the attendee control panel. You should see something that looks like this on the right hand of your screen. You're likely listening in using your computer's speaker system by default. If, however, you would prefer to listen over the phone, just select telephone in the audio pane and the dial-in information will be displayed. Webcams and audience microphones will not be used in today's webinar. Questions will be taken throughout the presentation. Please use the questions pane on your control panel to type and submit your questions. Finally, today's webinar is being recorded. I would now like to introduce your presenters, Dawe Reynolds and Maurice Dawe, educators with the Drug Education Network, or DEN. Before joining DEN, Dawe worked in the homeless and mental health sectors as a project coordinator training health workers working with Aboriginal clients. Following the successful completion of this project, Dawe joined the DEN team as an educator. Dawe continues to work in the alcohol and other drug sector as a drumbeat facilitator with Hollyoake, Tasmania, as well as developing and delivering group work at the Tasmanian Men's Gathering. Maurice is a qualified social worker who holds a fine arts degree. He has worked in the welfare sector for the last 20 years. His professional experience covers PTSD counselling, drug and alcohol counselling, family and relationship counselling, mental health, and court and family mediation. Welcome, Dawe and Maurice.
Thanks for that introduction there, Stephanie. My name is Dawe, and I've been here at the Drug Education Network for around the last 3 years or so. And as you mentioned there, prior experience of around 10 years in the drug and alcohol sector. I've worked in one-on-one counselling sessions and in group work sessions in that sector, as well as then working in the mental health sector as an AOD, alcohol and other drug specialist, and again in the homeless sector as a drug and alcohol specialist as well. I'll hand over now to Maurice, who will also introduce himself.
Thanks, Dave. Thanks, Steph. Hi, I'm Maurice. I've been with the Drug Education Network for nearly 5 years. I've worked with the sector for over 24 years as an AOD and family relationships counsellor, working in the correction system and in group work rehabilitation programs. I have focused on many and varied forms of addiction over that time, but had a primary focus on AOD specific work over the last 12 years. Just in the way of introduction, we're DEN. We've been around for 32 years, originally established by the Lions Clubs. And you can access our resources on these screen sites at facebook.com/drug education network, at pinterest.com/drug ed tas, at youtube.com/drug education network, and at twitter.com/den-tas.
Thank you, Maurice. I'm just working with the technology here. There we go. So this is our position statement on drugs and alcohol here at the Drug Education Network. So the Drug Education Network, here we neither condone or condemn the use of drugs, but rather we do acknowledge that drug use exists, irrespective of the legal status or societal norms. And we work here again to provide our community members with resources, information, and the connections that they need to keep themselves and the community safer in relation to their individual circumstances. And our goal is to meet people where they are and to encourage open dialogue that empowers the individual to be the primary agent of their own physical, mental, and emotional well-being. So our session today, there's a little outline here. So given that October is Safe Work Month, which is a time when workplaces are being encouraged to think about and to start a discussion about how to improve work safety, we all know that preventing an incident from occurring is far more cost effective than trying to deal with an incident after the fact. So now is the perfect time to start the conversation around drugs and alcohol in the workplace. And we've put together a presentation that we're going to show you today that we hope you find interesting and informative. The outline is you can see on your screen there. So initially we'll introduce the Drug Education Network, let you know a little bit about us. Then we're going to go on to have a look at which drugs are harmful and how much harm they do. We're going to discuss the prevention of drug misuse and in terms of the cost and benefits of policy. Then we're going to dig deep into the key strategies. We're going to have a look at policy, education, communication, and workplace culture and how they relate to drug and alcohol use. We're going to have a look at workplace drug testing to consider what the best practice considerations are in that regard. And then finally, we'll show you some of our DEN resources, including a video that we'll show you towards the end. And we'll have a chance to ask any questions that haven't been asked by the end. You can ask those at the end of the session, but feel free to fire in any questions that you've got in the chat box, as we mentioned earlier, as we go through.
So before we start to talk about the drugs themselves, let's have a little look at what we mean by prevention. DEN supports harm minimisation approach and supports the notion of prevention in this context as one of preventing harm and the misuse in the workplace with its detrimental effect on individuals, workmates' health and safety, as well as productivity. On the screen at the moment is a resource that we produce, one of our DEN files, that deals specifically with the prevention of harms. So what does prevention look like? Preventative actions may include projects or programs, information and education, media campaigns, research, particular ways of working, for example, community development, as well as policies and legislation. Some examples of Tasmanian preventative actions include healthy eating and physical activity programs to prevent obesity and diabetes, anti-discrimination legislation to promote equality and prevent stigma-related mental health problems, community gardens and men's sheds to prevent social isolation. In AOD specifically, AOD prevention looks like, well, when it comes to alcohol and other drugs, prevention is about taking actions to stop or delay the uptake of drug use and protect against the progression to harmful use. Like other prevention programs, AOD prevention involves a range of different approaches. Two terms commonly used in AOD prevention are early intervention, which provides specialist intervention early in the experimental phase of AOD use to prevent it from progressing, and harm minimisation, which aims to reduce harmful effects to self and others. One thing that we do know is that substance use is frequently in the media at present, particularly as we navigate our way through the COVID pandemic. We often receive referrals from business owners seeking information and expressing concern about substance use amongst their workforce and its impacts on the workplace. And many are seeking support in formulating effective drug and alcohol policies.
Thanks, Maurice. So, which drugs are we talking about? When we talk about drug use, many people immediately think about the illicit substances such as crystal meth or ice and cannabis, or perhaps ecstasy use. But in this context, when we're talking about drugs, we also want to think about the impacts of tobacco, alcohol, and prescription medications. So alcohol was responsible for a total of 4,186 deaths in 2017. And in comparison, in 2018, NDARF reported that there were just 99 amphetamine-induced deaths in Australia, which is at a rate of 0.4 per 100,000 people. So what we see is that the legal drugs are consistently causing more harm than illegal ones. Whereas the media reports, of course, widely on the effects of the illegal substances, stigmatising the users of those drug types. And it's worth noting that many of the younger generations see a great deal of hypocrisy in being lectured on occasional ecstasy use in light of the significant harms and costs that are associated with alcohol misuse. Now, what we do know is that the more frequently and heavily a person uses a substance, the greater the risk of harm. And so when people move from experimentation to more sustained use, the risk of harm increases. Social norms and culture greatly influence substance use patterns, both in society and in the workplace. So some workplace cultures indirectly support substance consumption, both in and out of work time. An example would be beer o'clock on a Friday afternoon. So in the workplace, the implementation of harm minimization strategies combined with health and well-being programs can lead to a more productive workforce. So why do people use drugs? When we think about why people use drugs, it's useful to think about the different ways that people use substances, some of which are shown on this slide. So at the top there, we've got behavior management. So, for instance, people using alcohol or cigarettes as a reward. A cigarette break gets a person out of the office or off the work floor, and lunchtime or knock-off drinks I look forward to. Plenty of people you'll hear saying that they can't function without their first cup of coffee. People getting through the day are thinking about, a beer o'clock or perhaps smoking to relax during the day. So self-medication is another way that people might be using. And sometimes that can look like the preemptive use of painkillers to relieve stress or headaches. It could be use of medication to relieve the symptoms from overindulgence. It could be pain relief. People using substances for. It could be dealing with symptoms of mental health issues, which we'll have a look at later on. And then we have recreational use. So recreation is where someone is using a substance occasionally, perhaps at a celebration, maybe their grand final or at weddings or so on. Is social use, where substances are regularly used to enhance social situations, perhaps regular nights out on the town, or regular wine at dinner parties or so on. And then we have compulsive use, where a person is using a substance more than they intended to use, or using it on a regular basis when they start to experience loss of control. So drugs and mental health. If they consider the role of drugs and mental health, the way they interact, first of all, we'll have a think about that in terms of self-medication. So again, if you consider the use of tobacco or alcohol during the workday to help people get through the day and deal with stress, people taking that break. Some people might be using cannabis, for example. They might feel that that's faster in terms of than antidepressants in terms of dealing with their symptoms. Antidepressants might take a number of days or weeks to become effective, and people might see that cannabis might work quicker and also maybe less perceived side effects, particularly initially. So as a drug and alcohol worker, I've often worked with people who are using alcohol to reduce the symptoms of schizophrenia, people using meth to deal with depression, people using cannabis to deal with anxiety, and many people who've been using opiates to help with chronic pain. And when I'm talking about chronic pain, that's not just about physical pain, but that can also include emotional pain and the effects of trauma. So for some people, the fear of recurrence of their mental health symptoms can lead to preemptive self-medication. So people taking the medication to stave off the symptoms. And of course, that can lead to habitual use. So the issue here can be that the use of such substances might mask or exacerbate the symptoms of their mental illness. So substance use may well counteract or interact with prescription medications that a person is taking, which can lead to a cycle of worsening mental health as side effects of self-medication become more apparent over time. So where self-medicating and the counteraction of prescription medications is taking place, that can lead to other people losing faith in their prescription medications and therefore taking more self-medication, and their symptoms can worsen. So because of the stigma out there around both mental health and substance use, and because of the punitive processes that we have in society and the workplace, people using illicit substances may well not self-report to health professionals or their colleagues.
Thanks, Dave. Let's have a little look at the addiction cycle. Here is a model of the addiction cycle where an emotional trigger can lead to a craving and an increased substance use. I'll talk you around the model, starting from the emotional trigger. Emotional triggers can be any type of stressor. It can be like feeling depressed, maybe feeling anxious, maybe feeling uncomfortable with something you have to do, or being frustrated, or unhappy or angry. It may be because of illness or tiredness. It may even be some form of loss or grief. Craving. Craving is the desire to use a substance or to be free of the distress caused by the emotional trigger. The ritual. The ritual aspect of the cycle can include such things as drinking in a certain place or with certain activities, like fishing and having a beer, or having a beer while watching footy, or maybe having a drink at a concert. Ritual can be using in a regular venue like a local pub or a club, so there's some form of association, or using at a certain time of the day, the wine after work, the drink after a day in the garden, or maybe having a smoke to de-stress at lunch. All these things form patterns and rituals we can adopt without realising we are doing it. Substance abuse and addictive behaviours can result from these patterns and rituals, and the longer and the more that we use substance, the greater the risk of addiction. These behaviours often lead to guilt, shame and remorse, which brings us back around to the emotional trigger. Whilst emotional triggers may be a symptom of mental illness, they could also be a trigger from within the workplace. Some potential workplace stresses include interpersonal relationships, maybe bullying, deadline stress, work overload, maybe isolation, or the general work culture, maybe the Friday Arvey drinkings, or working from home during COVID. We'd like you to consider the next question and use the chat box to tell us some of your ideas about where you work. So this is the question. In your workplace, what are some of the potential triggers that could increase consumption? Type in your answers into the chat box and we'll have a look at it and discuss what comes in. So, what works to reduce workplace triggers and subsequent substance use is when we can recruit the whole workforce to take ownership of AOD use.
One response that's come in is stress, shifting rostering patterns. Sorry, shift rostering patterns. My apologies.
Yeah.
Most certainly.
Yeah, and the shift rostering patterns can bring, disrupted sleep patterns, which of course then people might be tempted to use something to help them get off to sleep, or they might be sleepy when they wake up and they might be using something to give themselves a bit of a kick along in the morning or before the start of the shift so that they feel able to focus. Yeah.
Further responses: 7 days on, 7 off. Poor job description.
Poor job description. What's that? Yeah. So yeah, 7 days on, 7 days off for sure. Again, those shifts really interfering with natural sleep patterns, which again are associated not just with drug and alcohol use, but also with mental health issues. It can be difficult to cope with those changing patterns. And did you say, Stephanie, poor job description? Was that the other one?
Yes, yeah, that was one of the responses that came through, as well as change to work pattern or conditions imposed, being performance managed, workload and deadlines.
Yeah.
They're all stresses, most certainly all stresses in most workforces. And understanding that also is about the stresses that those elements like the 7-day working roster can actually put on the social life and the social expectations that others have on that person, which can in turn become a stressor in itself. And that connection that we have to that reward process. I've worked 7 days, I need a beer. I need to sit down and have a good relax. So there are elements most certainly in those processes. And the job description. Sorry, Steph. Just
That's all right.
with the job description one, I think that's an interesting one in the fact that that sounds like there's some sort of tension between the role that the person's actually playing and how that job that they applied for was actually described to them, which, yes, most certainly would produce significant stress.
A further response, working in a close team environment, peer pressure.
Very real.
Yeah, of course, it depends on a person's personality. For some people, being in a close-knit team is a very supportive thing, and for other people, they might feel really, really pressured by that situation. Absolutely, that could bring on anxiety. And we know that certainly drugs like cannabis often used to mitigate anxiety and alcohol as well. Absolutely, yeah.
Also, forced redundancy or outsourcing of work.
Yes, and those big life moments, if someone is losing their job and they really don't want to lose that position. Of course, if someone has been using substances up to that point as a way of dealing with stress, then they're likely to continue to use that substance as a coping mechanism at that point when the stress picks up. That's for sure. Yeah.
Also, unexpected events. So, for example, COVID and working from home, which you mentioned.
And I think that's very much acknowledged as being part of the stressor when the routines become disrupted, when people's life patterns become very, very disrupted. People are more prone to seek solutions to help them deal with anxiety or any issues that occur, most certainly.
Yeah, and we've seen reports of quite large increases in the number of people who are drinking in the daytime since they've been working at home, whereas perhaps they go to work and then they might come back and have a beer after work. If they're working from home, they feel more able to have a drink during the day and earlier during the day and still be present, show up at work from home with some alcohol on board. So we've certainly seen an increase in daytime drinking, and I imagine in daytime substance use across the board with working from home, absolutely. Added to which the sense of isolation. I mean, perhaps not so much down here in Tas, but some places on the mainland where people are very isolated, again, that can bring a lot of fear and anxiety, and understandable that people might want to self-medicate. Yeah, absolutely. Thanks, Stephanie. Okay, so let's move on to our next slide. Thanks for your input there, for typing those in. That's excellent stuff. So let's have a look at some statistics about where in Australia substance use is happening. What we do know is that people in remote and very remote areas were twice as likely as those in major cities to smoke daily. So we're talking about tobacco smoking there. And again, running at 19.2% compared with 9.8% in the major cities. And we know that people in remote and very remote areas were about 1.6 times as likely as those in major cities to consume alcohol at levels that exceeded both the lifetime risk guideline and the single occasion risk guideline. One moment, there we go. So as you can see, Tasmania is considered outer regional, remote or very remote, which is where the data shows that increased risk of excessive alcohol consumption and high rates of smoking. Okay, now this slide compares smoking, drinking and illicit drug use across major cities, inner regional, outer regional and remote areas. And it shows that across all categories of substance use, remote and very remote areas are at the highest risk. I'll just let you have a little look at that for a few moments. Of particular interest here is the fact that 38% of remote and very remote drinkers consumed alcohol at risky levels on a monthly basis. Yeah. So although the recent household survey from 2019 doesn't have comparable stats in a graph like this one, and this graph is from a few years back, but it shows the use of illicit substances across the Australian states. Yeah. And on the next slide, we'll dive in and have a closer look at Tasmania. Actually, on this graph here, we're looking at cannabis, ecstasy, cocaine, methamphetamine, and any other pharmaceutical medication. And so diving into the Tasmanian figures, what we can see here, again, the quick facts part there, we have in Tasmania in 2019, amongst people aged 14 and over, 1 in 8 smoked tobacco daily. 1 in 4 consumed 5 or more drinks in one sitting, at least monthly. 1 in 6 used an illicit drug in the last 12 months. And more than half supported testing of drugs and pills at designated sites, which is a bit of an aside, but interesting fact. In terms of the people exceeding the lifetime risk of alcohol consumption, we have some good news in that in 2007, 23% of people were drinking at a level over their lifetime that would increase their risk of harm. And by 2019, that was down to 16.6% of people. So a fair decrease there actually in problematic lifetime drinking. And in terms of drinking on a single occasion to a level of risk, in 2007, 34% of people were drinking at that level. And again, that's dropped down in 2019 to 26% of people. So there's a bit of good news there. And finally, in terms of daily smokers, whilst we do have high daily smoking rates in Tasmania, we've gone from 2001 where 21% of people were smoking every day, down to 2019, down to 12.8% of Tasmanians smoking every day. And that still equates to about 60,000 people in Tasmania smoking every day. And again, you can think about the implications of those sort of numbers on your workforce and your health in terms of absenteeism and lost productivity with the cigarette breaks and so on. But there is indeed some good news here on this slide around changing attitudes and behaviours in Tasmania concerning smoking and drinking rates.
Thanks, Dave. So let's quantify the problem. Alcohol and other drugs cost the Australian workplace an estimated $6 billion per year in lost productivity. Australian workers admitted to taking almost 11.5 million sick days as a result of their alcohol and/or other drug use. 1 in 10 workers say they've been affected by a co-worker's use of alcohol. For example, a reduced ability to do their own job, involvement in an accident or a close call, and having to work extra hours to cover for a co-worker. So, here's a couple of examples of what that stat may mean in real life. So you have a person working as a trainer, presents to work, and the colleagues can smell alcohol on their breath. An outcome of this could be that there may be damage to the company's brand for the organisation, and there are obviously health and safety issues at play here too. Or a staff member presents in a hazardous workplace and shows a positive test for alcohol, and the employee is sent off-site. The cost to the workplace is lost time and lost productivity, and the impost of someone having to refill that position. Let's have a look at methamphetamine and high-risk workforces. When we think about methamphetamine, we know that certain sectors of the workforce are at greater risk than others. Workers aged between 20 to 29 who are male in blue-collar industries like wholesale, construction, mining, manufacturing, and hospitality. How long the drug stays in the system? Because the way of testing is for the metabolites of the methamphetamine in the body, which are the substances produced as the methamphetamine is metabolized rather than the drug itself. And it can remain in the system at detectable levels for between 2 to 4 days. Cannabis can be detected in the body for up to 6 months after use, depending on the test. It is stored in the fat cells of the body and can be released as the fat stores are metabolised. Most users will produce a negative urine test after 6 to 12 weeks. Saliva tests for cannabis can show positive results for 48 hours after use. None of these tests are for impairment, only for the presence of the drug itself. So let's look at a comparison of drug harms in the workplace. Absenteeism due to injury, methamphetamine 16.9%, other illicit drugs 10.3%. Absenteeism due to illness 42.3% against other illicit drugs 39.5%. Absenteeism due to alcohol use 12.5% as against other illicit drugs 6.4%. Working under the influence 31.6% as against 6.0% for other illicit drugs. The NCETA conducted an analysis from the 2013 National Drug Household Survey, and their analysis showed significant differences in harms between methamphetamines and other illicit drugs. One of the key concerns from these statistics is that almost a third of methamphetamine users stated they had worked under the influence of the drug at least once in the last 12 months, compared to other illicit substances at 6%. This poses an interesting question. Why would people feel they need to use stimulants in the workplace? We might have a look at this a little later on.
Thanks, Maurice. So I'm just going to have a little slide here that talks about dual diagnosis. So dual diagnosis is where we have addiction issues alongside mental health issues. And we know that 50 to 75% of people presenting for substance use also have a mental health issue. The other stat that we know is that only around 2% of people who are suffering what we call comorbid or dual diagnosis problems actually receive support and help, only 2%. So in young Australian adults between 15 and 24 years, a high proportion of the causes for disease in both young males and young females were substance disorders, mental health issues, or both. And issues for young people include alcohol dependence, bipolar affective disorder, cannabis usage, methamphetamine usage, generalized anxiety disorder, schizophrenia, heroin usage, depression, MDMA usage, ecstasy usage, party drug usage, borderline personality disorder, social phobias, and eating disorders. And we know that the stigma of addiction is a major barrier to seeking help. So one example of this comes from a recent story of a young woman who was seeking support for her methamphetamine or ice use. And she said, when I talk about my ice use, people expect violence, and so that's how I get treated. So she experienced fear and hostility when seeking support, and it's worth remembering that most methamphetamine users do not behave in that manner. So again, that speaks to the stigma that's out there around that substance use. So legal drugs like alcohol are culturally acceptable in certain circumstances, and we even have names for different types of drinkers, you know, like a heavy drunk or morose drunk, angry drunk or happy drinker. You know, you can consider how a person might have two sort of versions of themselves. You know, it could be John, who's the life of the party, and also John, who's the alcoholic. So there's some cultural distinctions there that we see in Australia. If you consider the contradiction that can exist between safe drinking levels and workplace culture, after work drinks, people wearing their hangovers as a badge of honor, you know, like I had a really big night last night, you know, that kind of thing. We can see that workplace culture can be a barrier for people seeking support. And we know that apprentices will base their behavior on that model by their elders and the leaders. So on top of the stigma surrounding illicit drug use and the cultural barriers around seeking help for alcohol use, another significant barrier to people seeking support is the stigma surrounding mental health, mental illness. There's still a lot of fear and ignorance in our community and in our workplaces around mental ill health, and this can result in feelings of shame that can prevent or make it much harder for people to actually reach out for support.
Thanks, Dave. So why prevention of alcohol and drug harm in the workplace? The workplace can be a unique and cost-effective setting to implement public health strategies to address alcohol and drug-related harm. Social norms. The workplace can be a safe place for safety messages to be accepted and be usable. Most people who drink alcohol or use drugs are employed, so the workplace provides access to people who might need but otherwise not seek assistance. Full-time employees spend substantial time at the workplace, which maximises opportunities for their exposure to prevention and intervention strategies. Employers have a substantial influence over employees' work-related behaviours, particularly those that are relevant to workplace safety and productivity. Industrial relations and OH&S legislation and frameworks incorporate alcohol and drug-related issues that affect the workplace and employee well-being. Messages concerning alcohol and drug harm prevention and minimisation delivered in the workplace are likely to influence the wider community via employees' interaction with family, friends, and other social networks. Opportunity. The workplace interventions can overcome many common barriers to treatment and prevention, especially when drug use is not perceived as a problem in the workforce, or there's a lack of motivation, or work commitments seem to generate a demand for use, or there's a lack of support in management, or a lack of awareness of treatment options. A study called Methamphetamine Use in the Workplace, Options for Prevention and Treatment by Ken Pidd, of the NCETA, has described some of the factors within workplaces that can increase the likelihood of methamphetamine use. Within the workplace environment, they include availability of substance at work from other employees, the workforce demographic, the location, supervision level, and policy response, working conditions, shift work, long hours, fast-paced work, fly-in, fly-out work. The report also highlighted that there may be workplace motivations to use, for example, to reduce fatigue, to increase productivity, or increase alertness. Because that particular drug moves through the body quicker than drugs like cannabis, methamphetamine can reduce the risk of being detected with a positive drug test. We know that a zero tolerance policy towards drugs leads to evasion attempts, resulting in a subculture of how to cheat and how to avoid detection. Here's an amusing little story about what can go wrong with evasion of drug tests in the workplace. A worker called John is asked to provide a urine sample for a drug test at his work site. John is worried about it because he knows that he's been using cannabis at the weekends. John has an idea about how to avoid detection, and so he asks his family member to provide a substitute urine sample, which he presents at the testing station. A few days later, the health worker calls John in and says, "Congratulations, John. Not only have you passed your drug test, but I'm happy to tell you you're also pregnant." Now that's a bit of fun, but the reality is that substance use in the workplace does present risks, and a good workplace alcohol and drug policy helps to keep everyone safe. So here are some campaigns you may have seen. Campaigns like "Real Mates Don't Let Mates Drink and Drive." I've seen that across TV quite a lot. And the Are You OK movement, which has raised awareness and prompted a lot of great conversations about mental health.
Thanks, Maury, and thanks for that gag there. Marvellous stuff. So you've probably heard of the term wellness being used over the last few years, and it's become a bit of a buzzword. The slide here shows some of the ideas that are associated with wellness. As you can see, there are words like relax and breathe and 2 litres of water a day, being active and positive, living a healthy lifestyle, and so on. But the question is today, what's in it for the employer? So there's no question that healthy employees cost employers less in benefits, in workers' compensation claims and lost work days, and improve worker engagement. The return on investment is profound. So a 2010 Harvard Business Review study showed that since 1995, the percentage of Johnson & Johnson employees who smoke had dropped by more than 2/3. High blood pressure declined by more than a half. And the payoff for Johnson & Johnson, estimated by the leaders, was a cumulative saving of $250 million on healthcare costs over the past decade. So from 2002 to 2008, the return was $2.71 for every dollar spent. So based on the Harvard study, wellness initiatives save an employer an average of $394 per employee per year, while the programs cost only an average of $159 per employee per year to deliver, creating a return of investment of $3.36 for every dollar spent. Canadian studies have shown comparable tangible results, and many insurance companies such as Mercer are offering percentage reductions in group premiums for organisations that are committed to invest in wellness programs for their employees. So in the Canadian study there, returns on healthy workplace reported by large private sector organisations range from $1.81 to $6.15 for every dollar invested.
Excellent. Thanks, Dave. So prevention begins with robust policy. A good policy framework addresses expectations expressed in simple and very clear language, provides a detailed approach for managing AOD-related health and safety risks, can be communicated widely and regulated to every staff member, and inform about consultants and contractors. Can apply to all workers and should include prevention, education, counselling and rehabilitation arrangements, and provide information for approaching a worker who may be under the influence of alcohol or other drugs. It can provide good reporting and detailed procedures for reporting AOD use, provide resources and information, and good education and training, provide counselling through support services like EAP, and clearly describe the disciplinary process that's engaged once that drug and alcohol test has been found to be positive. Now, positive tests towards drug testing were found in relation to transparency, upholding employee rights, and having a clear rationale for the testing program. Information about policy is really important in this. Information about drugs and alcohol, training of supervisors to deal with potential problems, perceived fair administration, and focusing on rehabilitation. Testing does have a role to play in improving workplace safety. However, for testing to have any impact on the workplace safety, testing programs need to be based on best practice. Best practice programs are those based on principles of quality practice and readily accepted and endorsed by employees. So what's workplace drug testing, or the best practice model? Any testing program, therefore, needs to be justified, fair, offer counselling, target safety-sensitive roles, allow employee input, have the right of appeal, be well communicated, and educate the workforce. Justified as a mechanism to address an identified risk and be applied in a procedural, fair manner. Offer counselling, treatment and rehabilitation options rather than punitive outcomes. Target safety sensitive rather than non-safety sensitive work roles, and allow for people or employees to input into the development and implementation of the program. To allow for a right of appeal and to adequately disseminate associated policy and procedures and incorporate appropriate education and training of the workforce.
Thank you, Maury. So I'll just give you a few examples here of initiatives and programs that have been rolled out. And here's an example of a poster that's been used for an anti-smoking campaign. You will have seen signs like this around the place. Here's another you may have seen, which is a harm reduction campaign which targets methamphetamine use. And it includes on the right-hand side there some harm reduction messaging. So, to reduce harm from methamphetamine, take a break from drugs, avoid daily use, look after your self-care, which is around sleep, food and water, avoid using alone, test before you use, and don't inject methamphetamine as a way of reducing harm. You may have seen this campaign as well, which is the International Overdose Awareness Day, which takes place every year on the 31st of August. And again, the key bits of information on this one, that 68% of all drug deaths involve multiple drugs, typically painkillers and sedatives and alcohol greatly increase the risk of overdose. So that was the right dose, wrong dose overdose campaign associated with International Overdose Awareness Day. Okay, so next slide here. In a moment, Stephanie's going to play a video. And now this is a video that you can use during your induction process if you want to discuss drugs and alcohol with new employees. Or again, it's a video that can be used at any time if you want to initiate a discussion about drug use and the workplace. Now, it is available via our YouTube channel with the address of which is on the bottom of the screen now, and also via our DEN Drug Education Network website. So we're going to show you this video now. It's about 7 minutes long, so you know what the content is, and you can consider how this video might form part of your workplace drug and alcohol policy going forward. And again, feel free to send us any statements or feedback about that video and how you think you might be able to use it. Okay, thank you, Stephanie. If you can show the video. Thank you, Stephanie, for showing that. Thank you for Maria, who was speaking there on that video. So that's a resource that you might be able to use again in your workplace, perhaps at induction, or if you want to start a conversation with the workforce around drug and alcohol use. That might be a way of starting that conversation, which might be a little bit tricky. So what I'm going to do now is hand over to Maurice to talk you through some of the other resources that we produce that might be useful for you in your workplace.
Thanks, Dave. So as we just heard Maria talk about the rough guide, which is a really useful little spin wheel and a good way to calculate the amount of standard drinks you're consuming. It looks at a wide range of alcohol types and examines how many standard drinks are in a particular serving. This enables people to be able to assess actually how much alcohol they're actually taking in. We also produce the older and wiser. We know in Tasmania we have an ageing population. We know in Tasmania we have long-standing problems with alcohol and maybe with prescription medications. Older and Wiser looks at some of these issues and it looks at our capacity to actually use alcohol as we age. It discusses alcohol use alongside medication and touches on other associated harms as well. Also, there is the Save a Life card, which is a simple wallet card that folds neatly in half with a clear info on what to do and who to call and what overdose looks like. It's good information and good information that we all need to know and understand. We also produce DEN files. DEN produces these well-written and well-researched papers on a variety of topics associated with AOD use. Recommended reading would be the files on overdose and prevention. And we also have the ALDAF brochures, the Australian Lions Drug and Alcohol Foundation brochures, produced by DEN in conjunction with the Lions Clubs of Australia. These brochures cover a wide variety of topics, including checking in on your own wellbeing, talking to others about drugs and cannabis, and are you worried? All these things are accessible via the DEN webpage or through the Facebook and Pinterest links. So now we'd like to open up the chat box again to answer any questions that you may have or that you may have already come in.
All right, thank you, Dave and Maurice. As it was said, we're now taking any further questions from the audience. Just to let everyone know, for anyone who wasn't able to view the video for various reasons, we will send those individuals who hooked into today's webinar the YouTube links. I don't think that you've missed it, or you need to wait until the recorded version of this webinar comes out. We will get that link to you by the end of today. So one question that came in earlier, Dave and Maurice, you talked on a previous slide about decrease in lifetime risk and single risk, and that was 2007 to 2019. Do you think that for 2020, COVID will see an increase?
Yeah, what a great question. We won't know for sure until the data comes out, which will be the following year. So in 2021 we'll get the data out for 2020. But there is a fair bit of data coming in now, as I said, is showing an increase in daily drinking for sure. And we're also seeing large spikes in retail in terms of the bottle shops and so on, selling a lot more alcohol at the current time. So there was a huge spike when COVID first started. And part of that may be down to the fact that people aren't drinking at venues such as hotels, pubs and clubs so much. But what we think is happening is that there is in fact been a huge spike in alcohol sales and consumption. That is what we're expecting to see. When I work currently, when I'm working alongside drug and alcohol service providers, what they're telling me is that the people who are presenting to them with drug and alcohol issues are actually struggling much more at the current time as well. So the people who are already many people who are already struggling with drug and alcohol use. The COVID has exacerbated their situation and has resulted in more consumption, sometimes difficulty with people being able to access their drug of choice. And so that creates a tendency for people who are sort of self-medicating to use a substance that they're not so familiar with. So we're expecting to see down the track more people turning up into counselling, looking for support as a result of COVID, COVID-induced stress. Yeah.
All right, thanks. Another question, can you comment on the media glorifying use of cannabis for medical treatment?
Yeah, that's a really interesting one. I go around schools with the Drug Education Network, and we talk to kids, and one of the questions that kids often ask is, well, isn't it legal now, now that it's medicine? So what we're seeing is that, and the way to think about this really is that medicinal cannabis is a very specific form of cannabis. That's reproducible, so that the plants that it's grown from are cloned, and so you get exactly the same amount of the active ingredients, the cannabinoids, in the same balance in each plant. So and you get a measured dose. So one of the big differences between that, of course, and cannabis that people are buying on the street is that there's no real knowing the strength of that cannabis or the individual combinations of the active ingredients, the way that they interact with one another. And so there's a real difference between a controlled dose of medicinal cannabis and a street dose of cannabis. And of course, people who are smoking cannabis often will use as much as they want to, rather than an amount that's prescribed. So there is definitely a major difference there in terms of those two substances. And in terms of education, yes, it means that we need to be more nuanced in the dialogue and the conversations that we have with people, because there's clear evidence that medicinal cannabis does help for certain conditions and for certain people. It's not something that is universally prescribed to everybody for every ailment, obviously, and so it means that we need to be able to have nuanced conversations with people when we're talking about cannabis. Yeah. Have you got anything to add to that, Maurice?
I think what we're looking at really is an entry point. We know opioids have been used medically, medicinally, and very controlled for a long time, but they're also a dangerous drug when they're used illegally.
Yeah.
Cannabis has been shown to have certain properties that some people find very useful to help them manage certain difficulties that they may be going through. But again, they are prescribed, it is prescribed use, it is measured use, and the substance that's being used is not uncontrolled. And I think there lies the difference.
Yeah, thanks.
All right, thank you. Thanks. Another question. Our workplace has a predominantly volunteer workforce. The rail safety workers are totally banned from having drugs or alcohol in their bodies. What sort of control should we put on those who represent us at official social functions?
Oh, that's a great question again.
That's a good question. Yep, that's a good question.
It is. Would you like to talk to that, Maurice?
I think that comes into policy. I think the policy that is written around alcohol use and how the organisation actually determines what is the workplace. The workplace is not just the place where you physically utilise your tools or work in the garage, but it is a space where you represent the organisation that you're working for, whether that's a paid or voluntary position. So I think it is about well-written policy that explains in very clear language about the expectations that are required and about the organisation's policy, which may be zero tolerance around drug use in those environments where they are actually representing their organisation.
Yeah,
all right, thank you.
I think also in general terms that then we would be encouraging drug and alcohol policies to be written from a health perspective first, to consider substance use as a health issue primarily, before it's considered as a legal or issue. Yeah, I'll probably add that as well.
All right, thank you. Can you talk about which drugs would be found in a breath test, in a blood test, in a urine test, for example?
Yeah, so there are a lot of different types of testing, so it's a bit tricky to answer that in a general question like that, because there are many different types of testing, and tests can be purchased, and testing regimes can be used that check for many individual substances. Again, some substances that people use are out of their system very quickly. Substances like opioids and methamphetamine move through the system very quickly. Drugs like cannabis stay in the system for a long time. I've worked in programs in the past where people have been have the opportunity to give a urine test when they've started the program, and again at 6 weeks, and again at 12 weeks. And those tests in that situation were looking for amphetamine use, for opioid use, and for cannabis use. And what we would see is that people, if they were heavy cannabis smokers, at 6 weeks, often they'd still be showing up in that urine test, even though they hadn't used. But by 12 weeks, the vast majority of people were able to provide a urine test that didn't contain any traces of cannabis. So it really does vary on the actual test that's provided. And again, yeah, it's difficult to answer that one in general terms.
Yeah. Different tests will can provide different levels as well. Some tests are more accurate than others, so it can be a sort of very difficult area.
All right, thank you. Is there any free testing? Is there any free testing centre from government? So if an employer wanted an employee to get tested?
So I believe that GPs can offer that service. Yeah, I don't know of any centralised government testing facility, but I believe that you can go to a GP and get a registered test. And I think potentially, I know when I was in New South Wales, certainly some pharmacists offered that test, but it does require that the person is there and they're witness providing the sample, so it is a little bit onerous on the person providing the test. But I believe that some GPs will provide that test. Yeah. Are you aware of anything, Maurice?
No, I'm not, Dave. In respect to that, I don't believe there is any government issue apart from GPs. I believe they're the only ones that will do that.
Yeah.
All right, thank you. And just to finish up, a comment has come through in respect to one of the questions and responses that you gave. I think it is so important to link your wellbeing program to include diet, exercise, mental health, and substance use.
Yeah, absolutely,
Yeah,
absolutely. Yeah, that holistic approach is the way to go, and to see, substance use as part of that wellness drive. Absolutely, we would be encouraging that. Yeah, absolutely. That's great comment. Thank you.
Very good.
All right, thank you. Oops. So thank you, Dave Reynolds, and thank you, Maurice Dawe, both from the DEN for presenting today's webinar, Alcohol and Drug Use in the Workplace. It's a health and wellbeing issue. The DEN contact details are on the webinar at the moment, so if you wanted to get those details down. Again, for anyone who was unable to watch the YouTube video today, we will get that to those people who attended today's webinar as well. So once you do leave today's webinar, you will receive a survey on the presentation. We appreciate you providing us with your feedback. Also, today's webinar has been recorded and it will be made available at the end of WorkSafe month on the WorkSafe Tasmania website and also on our YouTube page. So on behalf of WorkSafe Tasmania and the WorkCover board, thank you for joining us, and thank you, Dave, and thank you, Maurice.
Thank you.
Thank you.